All right. So the first topic I wanted to kind of touch on was appendix ultrasound. So before I get into a couple cases, I just wanted to start off with a couple of discussion points. So first question for you guys. We've kind of gone back and forth on this. What do you guys do if you don't see the appendix and they don't have any secondary signs? Do you call that a negative study, or what is your kind of general thoughts on that?
I love being descriptive. So, first of all, I think I and our group, we often forget that pain is a secondary sign. So we're allowed to use that as like, even if there's no ultrasound evidence of inflammation, we don't see anything. If the kid has pain, that is a secondary sign of acute appendicitis. So they need to like further work up that child if they haven't gotten labs, then get labs, etc. Yeah.
So I use like like standardized report with like just specific findings like Judy, just basically describing everything, but then kind of summarizing it in like either the non-visualized category or appendicitis or equivocal. So like those kind of like scoring systems. So I kind of stick to that, and it seems um okay, because then I feel like the clinicians, when we say don't visualize, they don't go straight to a CT. They kind of just then further work up the patient clinically to see if a CT is warranted or not, CT or MR, depending on.
Yeah, I've seen some standardized reports where they say, this is a category 1, 2, 3, 4 in their impression, which I
Mhm.
find can be confusing, especially if you have trainees coming from multiple different places. So I love a descriptive impression. Like we see it as positive, we see it as negative. We don't see it, but there are signs, or we don't see it and there aren't signs, or that I love being descriptive, like in all things radiology life. So
Yeah. So do you guys, I guess the follow-up questions is if it's not visualized, but there are inflammatory signs, do you just straight up say most likely appendicitis and then
that's when I say correlate with our we used to say the pediatric appendicitis score, but now they call it, there's a pediatric appendicitis risk calculator, which theoretically, before they even come to ultrasound, they have calculated that risk, and it's a high enough pretest probability to go to need an ultrasound. But I find that is not the case at all. We are at our institution, especially like this time of year, they are ordering these studies from triage before an attending or any physician or a practitioner has seen the patient. So and I kind of agree with it. Just as a mom, like, would I want my child to have a potentially an IV, like a blood draw, maybe an IV, or just go to this non-invasive, pretty I always say pretty cheap. It's not cheap. Ultrasounds are not cheap at all in our department, like at least what's billed. But it's definitely an easy task. It's much easier than a needle stick, I feel like. So I don't know. I have mixed feelings. So when we have one of those, like we don't see it, but there are secondary signs, for example, pain only, that's when they have to then like put their like thinking cap back on and say, okay, well, did we actually think this patient had acute appendicitis or not? So yeah.
Yeah, and I put our template. We use one of those kind of scoring kit system for different categories. So I'll show you that after this slide. I should have put that on this slide, but I'll show you that in a second. As far as that was one of the questions I was going to ask later on, but we can go ahead and chat about it now. Is the kind of doing ultrasounds out of the waiting room? Is that something you guys allow? That's kind of come up for us lately. They're kind of leaning more towards not letting that happen. We are having some conversations with our leadership, and they're kind of leaning more toward just having the only thing that can be ordered from the waiting room is extremity radiographs. But the issue is like, especially now, like our ERs are so busy that kids are in the waiting room for a very long time. Appendicitis isn't as quite as emergent of an issue, but things like torsion, we don't want those kids sitting in the waiting room for several hours before they can get an ultrasound. So I think there's arguments on both sides. So how are you guys handling that issue? Are you letting them get ultrasounds done before they have a clinical provider actually assess the patient, or what are your thoughts on that?
Yeah, unfortunately, I think our ED is so busy now that they haven't gotten a chance to see a lot of the patients because some of them are waiting for so long. So we do still allow for like prioritization of certain orders such as torsion, like so scrotal, pelvic, stuff like that. And appendicitis, I think, has been kind of slowly slipping through as one of those that are done just from patients in the waiting room. And I have called ED to say, hey, there is appendicitis. And then they kind of like, in a way, like I'm helping them triage. It's like, and then they just pull the patient and then have surgery, see them all while in the waiting room. So I don't know, good or bad.
Yeah, when we talk to our ED leadership, they don't order ultrasounds from triage. However, multiple times I call a critical finding and nobody has seen the patient yet. So I know for a fact it's happening. I also know that in triage, when like you have a female with right lower quadrant abdominal pain, they start filling and they order that from triage. Like it's in their guidance. So I really feel for our ED colleagues because they are, anything we can do to help them triage, but also I just have really mixed feelings because also there's a huge problem of over ordering. And so when somebody who is, a physician or an advanced practitioner hasn't seen the patient, the problem of over ordering is even a worse issue. But sometimes you just smile and say, yes, the patient that, oh, you haven't seen this patient? Well, go see them. They have acute appendicitis or intussusception or whatever it is. So
Yeah, and
I
the
guess
other
the
right,
other
like
problem
everybody.
too. Oh,
Sorry, go ahead, Adri.
oh, no, I was just wondering, like, do you guys have issues where the report goes out and then the family already reads it and then they just leave if it's a
Yeah.
negative?
I
Like,
have
just like
heard of
no
that
abnormalities
happening.
found.
Yeah, I've heard that happening, but I have not personally experienced that.
Yeah, we've had a couple where, they get the reports pretty much immediately in their My Chart, and you know, I don't think everybody fully realizes that like there's other things they need to work up. Like ultrasound's a very specific question. Like just because they don't have appendicitis doesn't mean they don't have anything else. But they'll see that they think they have a negative ultrasound, and then yeah, they'll leave from the waiting room. And I don't think that's ideal patient care. We also don't get paid for
Um,
these studies after the fact either. So yeah, there's definitely issues with that. That's one of the downsides for sure. Yeah, pros and cons to both for sure. The next couple of questions I had were kind of like QA related questions. I'll just put both of these up here. The first one is for part of your protocol, do you have any kind of standardized metric for declaring a non-visualized appendix? Like, do they have to scan for a certain period of time or use different positions, or do you have that as part of your protocol written into it?
we do. Ours is 20 minutes.
Okay.
So first of all, if they see the appendix faster than that, they're done. Or if they see something else abnormal to like explain the pain, then they don't have to look for 20 minutes, but ours is 20 minutes. We actually don't currently have somebody going through and like re-reviewing all of our appendix ultrasounds at this time. We just don't have the staffing to do that. So if I happen to notice it or somebody who is persnickety, like I will send them back. Or even worse, that's when I say, oh, I'm gonna go scan now, which they don't like because they've already called transport, they've already like moved on with their life mentally, even if the patient is still in the department. Yeah, so
Yeah, we have one sonographer that she tracks all of our individual sonographers' visualization percentages, and like theoretically, the ones that are kind of have a lower percentage should kind of pair up with the ones that have, we have some sonographers that are consistently like very close to 100% for several months in a row. Like ideally, like they should be sharing their tips and tricks with everyone else. That's kind of what our QA program is. I think it's evolved over time. Like when it first started, it was a long time ago, and we weren't doing that many appendix ultrasounds, and now we're doing, like 300 or 400 a month, and this poor sonographer is still stuck looking at all those and kind of tracking all the visualization rates. So I don't know. It's a lot of work, but yeah. So we used to not have a time in place, but we recently put that in, and I think we put it at 15 minutes. So I'm not sure if how it'll change things, but we're gonna try that out and see how it goes.
yeah, we
So
have
did
our
that,
tech. Oh, go, sorry, ahead.
oh no, I was wondering if that particular sonographer has dedicated time separate to do all that, the QA.
So we have like a career ladder program. So she gets points towards what we call Tech 2 here. So she doesn't have like dedicated hours of her day to do that. But if she's working at one of our off sites and, has a slow day or something, she'll just do it while she doesn't take time outside of her typical work hours to do that. So she kind of indirectly has time, but she should have dedicated time, but it's not how it's set up currently.
Yeah, we had an overnight tech in her downtime as part of her Tech 2 project, go look at the numbers and also like look at the outcomes. My like thought process was we can maybe curb some over ordering. But then she completed her project, she got promoted and has moved on to helping us do other things in the department. So
All right. And then as far as our templates here, so this is kind of what we do. So this is our reporting template. So we say visualize, say diameter. This is kind of interesting. Like a lot of the historical papers, they report on appendiceal diameter. They're not very specific about whether it's with or without compression or how much compression, but we do specify with compression. We say whether it's compressible or not, talk about fat, vascularity. Vascularity I find challenging. Like we sometimes will see especially superficial appendices look very vascular, especially with our higher frequency probes. So I don't personally put a lot of stock on that. Say appendiculate, fluid, and perforation. So that's kind of our overall reporting template. And then as far as the verbiage, so we have 6 different categories. These are kind of tied into a overall kind of clinical pathway that we use. Similar to you, Judy, theoretically, these patients should have an Alvarado score calculated before they decide whether to do an ultrasound or not, but that's kind of a suggestion more than a thing that actually happens in real life all that often. But we do put all these into one single low probability category. So if they are either visualized, partially visualized, or non-visualized, and they have a good body habitus, then we put all of those into the low probability category. Those in our clinical pathway should go on to like what they call a diagnostic timeout after that to see if there's still clinical concern. Occasionally we'll still get a CT out of this category, so they are not totally dismissing this, but at least thinking about it. We also have this second low probability category for non-visualized with the suboptimal body habitus for patients that have more abdominal wall fat or gassy or whatever. Then we have these 3 different high probability categories. So we have one that's just acute appendicitis, one with perforation. Then this last one is the non-visualized appendix with secondary signs. So if we see inflammation or whatever, then we can put them in that category. And then we try to avoid this intermediate probability category, but this is when we see the appendix, but we're just not totally sure about the findings. Sometimes it's kind of equivocal if it's kind of borderline in size. We're not totally sure about the surrounding inflammation or things like that. So we try to avoid that, but we do have that as another option as well.
do you then recommend a repeat ultrasound in like 4 hours or something like that, since you could see it at ultrasound?
That's what I wish would happen. So these basically, it's kind of at the determination of pediatric surgery after that. I would say most typically they just go straight on to have a CT. I think more appropriately would be to observe them and do a follow-up ultrasound. I think like we've talked about before, if you see the appendix on ultrasound, I think that's almost more diagnostic than either a CT or an MRI. Like sometimes, especially in these younger kids, like we do a CT and the appendix is this tiny little glob, like you can't really see much detail in it, especially if they don't have much fat around it. It's hard to tell if it's inflamed or not. So if we get a good look at it on ultrasound, I personally don't think that CT adds a whole lot of information. I think the non-visualized ones are a little bit different, but those intermediate ones, I think in real practice, most often they get a CT, but I think ideally they would get observed and get a follow-up ultrasound. But all right, then just one interesting case. So I think we've talked about this before as well. So this is a patient came with abdominal pain and fever, has this very dilated appendix, so a little bit over a centimeter in size, not really compressible, super hyperemic. I'll play through this little stitching clip as well. So one thing that's kind of interesting about this is this lamina propria layer. This hyperechoic layer is very thick. There's really not much inflammation around this for how dilated and just kind of how diffusely abnormal in appearance it is. So this one did go on to have go into surgery and have this resected. So this ended up being lymphoid hyperplasia at resection. So I think we've talked about this before, but I think it's just kind of a interesting diagnosis that I think we're learning more and more about. So this is their normal appendix. So this hypoechoic layer, so they say it should be less than 1 millimeter in thickness. This is one that has lymphoid hyperplasia. So you can see this hypoechoic layer is thicker, like in our patient. So they say that this is kind of an older paper and it's kind of a smaller study series, but they say non-compressible 6 to 8 millimeters. And if they have one, you can have up to one additional secondary finding. But if you have at least 2 additional findings, then that's when you start thinking it's truly appendicitis and not just lymphoid hyperplasia. But more and more we're seeing this, I don't know, this thickening of the lamina propria. I feel like we see that more often now with our better technology. It seems to go along, if they just have like a enteritis or something like that, I feel like sometimes we'll see that. Not necessarily see this, non-compressibility and this more dilation of the appendix, but I feel like we do see that more and more often. But just kind of an interesting thing to kind of be aware of. We did actually have a patient that came in with an appendix ultrasound. They ended up having leukemia. They had a very similar appearance to this one, kind of had this leukemic infiltration of their appendix in it. Again, with that kind of lamina propria thickening. So that was kind of their initial presentation, which was kind of interesting. So switching gears a little bit. So this is a patient came in with vomiting and lethargy. Again, I'll play through this cine for you here. So this is a kind of this very abnormal, kind of thickened and hyperemic segment of bowel. Looks like it kind of adheres to the undersurface of the umbilicus here. So this ended up being a Meckel diverticulum. So I feel like this is one of those other things that's not recognized super often on ultrasound, but it has this kind of characteristic appearance. It has this kind of crenulated pattern of the wall, hyperemic, and has some of these kind of fluid spaces within it. There was a paper published not too long ago from, I want to say China, that they compared ultrasound to nuclear medicine Meckel scans, and they showed that ultrasound is actually pretty similar. So I feel like we're, again, recognizing this more and more often on ultrasound, but sometimes I've seen this get passed over as just kind of a inflammatory enteritis or something. But I feel like when you see these kind of cystic spaces and this, it's hard to see, I feel like, the blind end of it occasionally, but when you see it associated with the umbilicus, that's another thing that can kind of go along with the Meckel. So again, just kind of another kind of interesting case to be aware of. Couple other general discussion points I wanted to chat about. What is your, especially for ER cases, what is your general approach to checking studies? So do you guys have every study checked, or do you only have a certain subset of diagnoses checked, or what is your general approach to that?
For ER patients, almost all of them we check. I wish we could get away from checking images so often, especially when we have well-trained sonographers that we know really well and they take notes. Sometimes the only thing that happens during that checkout session is they give me the patient's actual history, I have to say. So like, like they have pain, but like it's really chest pain or whatever, you know what I mean? Like sometimes that is the first history that's like actually legit documented for some of these patients, unfortunately. But yeah.
Yeah, I think it's challenging. We're getting more and more busy, and I think there's some subset of those, like you're saying, that we get that there's benefit, but a lot of them we're just looking at the images and say looks fine, and go on your way kind of thing. We've tried to develop like a subset of indications that they're supposed to check with us, mostly based on whether they think it's positive, like it's a positive torsion or things like that. But we have so many radiologists, like I feel like some people want to check more things and some people want to check less things. It's very hard to keep everybody happy. And then kind of same thing with the sonographer's workflow. Like it's easier for them to just get patients out the door and not have to check with us first, especially if they're in line with, we're on an evening, we're the only people around, and it's can definitely slow things down. So I think it's a difficult balance, at least for us.
Yeah. If we have a new PACS, which I just had a seizure because it's like in general not great. The one good thing about it is the sonographers can assign us the cases, and then that automatically pops it to the top of our workflow. So I will have days where I'm like, don't call me unless you have questions. If I need to, like, just we'll have a no check day, and then it just shows up in my queue. So like if it's a stat ER, that's the next case that pops up as soon as they're done with it. Yeah. But definitely if they ever have questions, I want them to call me and ask me, and
right.
like
Sure.
that with them. Yeah.
This one was submitted by our audience. So this was, if you guys have any tips for maintaining quality consistency, I feel like more and more we're doing ultrasounds when the radiologist is not on site. There's so many, at least for us, we have 5 different sites that ultrasounds are being performed, and 4 of them are covered by one radiologist, and the other site is covered by a single radiologist. So we have quite a lot of ultrasounds that are being done that even if we wanted to back scan, it's not physically possible. So I'm curious if you guys have any thoughts on how to maintain consistency and quality across that kind of practice model.
Yeah, we read for, I feel like sometimes more offsite locations than onsite locations. So we not only have children's hospital satellites, but the good news is those are our techs, those are our machines, those are our protocols.
Right.
So, and those, almost all of those techs also rotate at the main campus. So like, they know what they're doing. Right. We do read for UPMC, who knows where, Pennsylvania. They don't always follow our protocols. They don't always know what our protocols are. And so the rule for those is they have to call us, number one, so we know it's our case, like, because the work lists are very malleable, and yeah, I can't even keep all of these places straight. And so they have to call us to check the images, and that's really where that quality happens. Like, you didn't get cines or whatever it is, because they usually are following an adult protocol. So like they'll measure the aorta, like that's cute, but I don't care about that ever. Unless it's a vasculitis question. I shouldn't be so flippant. But yeah, that's how we deal with those. It's not ideal, especially because their machines are often very different.
Right. Yeah. Yeah. It's a challenge for sure. Next one, we already talked about this one. And then this is one we've kind of really struggled with lately is if you guys, I know it's very challenging, I feel like, for clinicians to appropriately order studies, even when they know exactly what they want, they order some random study that is not what they, and we have to get them to fix that. But, sometimes they'll put in, especially for vascular studies, like the indications don't match either arterial or venous or whatever they're looking for. We've struggled with this as far as kind of what degree of autonomy to give the sonographers to reach out to clinicians and try to talk them through what they really want. When do you involve a radiologist, kind of thing? I'm curious how you guys have handled this or approached this issue.
I feel like we give a lot of autonomy to our sonographers because I do think that they do these studies in and out, so they get a feel for what is an appropriate order. And then, but at the same time, it's an open door policy in that, if there is further questions that they cannot answer or they have any questions, they ask us first. But overall, like they kind of take care of like 90% of all, incorrect orders that are really obvious, and then come to us for like the remainder 10%. And then even then we'll talk it out. And if it's something easily conversable, they'll take the initiative to then call and kind of like convey what we spoke of. And I hardly have to do the actual like speaking to the clinicians unless there's like pushback or something that requires like higher escalation.
Yeah, we're basically the same. So as long as what is ordered matches the indication, like they do what's ordered. If there is something that doesn't match, they'll just call the ordering physician and like change. They do have the ability to change orders. I just had a meeting with my lead sonographer that I don't know about you guys, but we've had a lot of orders where the indication says nothing. It'll say other comma specify and be blank. And so what we just decided was we need to make the barrier harder so that people actually give us indications. So we're going to make the physician reorder the study, which is going to be a pain in the tail for them. And so I hope that we're going to not have this issue going forward, so that the tech knows like even what study to do. Like, does this match the indication? We did have a couple of issues with the sonographers changing the order with just talking to the bedside nurse in the past, not the physician. So like, I think the question was like leukemia or neuroblastoma, like a tumor or something. And like, but the indication said low platelets. And so they just looked at the spleen and that's what the nurse said. And then we like did not see this huge mass or whatever happened. So now they have to talk to the physician, not just the bedside nurse, when they're changing orders and clarifying what the actual question is.
Yeah,
Yeah.
and a couple of issues we've had is like when the sonographers reach out, like you said, they know exactly what they're talking about. Like they probably know as much or more than us in a lot of cases. And I think it's very unfortunate they don't necessarily always get the same level of respect as a physician or radiologist talking to them. Like they'll just kind of, the resident and whoever they're talking to can be kind of dismissive. And then once they involve a radiologist, the conversation kind of changes, which is unfortunate, but it's something we struggle with. The other issue is like there's so many layers of these orders sometimes. Like they'll consult ID or hematology or somebody and they'll say to put this order in, then the intern puts it in. They don't know exactly why. And we see their name on the order. So we call them and they just say, oh, this person wanted it. And these conversations feel like they get very convoluted sometimes. So there's so many layers to it. It seems much more challenging than it should be in a lot of cases to clarify these things. But yeah, it's a challenge for sure. All right. Well, that was my last slide. I'll go ahead and turn it over to you, Judy, to take it away.
Okay, let me see about sharing my screen. I was like so enwrapped. I was not getting my act together. Sorry, that's like a major Zoom fail. Okay. Hopefully you can now see my screen. Yes, we're going to continue the discussion. And I know this first topic is going to be Like the chat's about to blow up, but we're gonna talk about point of care ultrasound in the ED. I have strong feelings and I have mixed feelings, like usual. And then we're gonna talk about trauma, ultrasound in the setting of trauma, specifically in contrast enhanced ultrasound, because I'm me, gotta be myself. So we are super lucky that in our current schema, even switching to a new PAC system, all of the point of care ultrasounds get uploaded to our PACS. So when they do a point of care ultrasound, I can see that. Sometimes it's like, oh, just for vascular access, and it's something that's like not helpful at all. But sometimes it is legit images. So this was a case from actually quite recently where it was a 6-year-old who had flu, they had fever, clearly there's a pneumonia. Day 1, they had multifocal pneumonia and then complete whiteout of their right hemithorax 4 days later. And the point of care ultrasound saw the finding, right? So like there are multiple issues with point of care ultrasound. Number one, the machines that they're typically using are variable quality. They're just not as high end as ours. And that's usually, I think, appropriate because they're trying to answer a specific question. They are not getting diagnostic quality images. They're not following a protocol looking at, the entire abdomen or whatever it might be. They're looking for specific things to answer specific clinically actionable items. So you can see that there's a ton of mobile fluid in that right chest. The way most of their point of care ultrasounds are interpreted is they have like a interpretation on the screen of like their last image that they take, and then they save that. There is later after the fact, they'll put a separate note, so like interpretation note about the indication for the point of care ultrasound, the interpretation of the point of care ultrasound in the electronic medical record later. So you can see that this was not the best interpretation, but primarily they were looking at the cardiac function, which I thought was interesting. So a lot of what they're doing is not actually looking at the major finding, the major abnormality, but they're trying to like look at, what is the reason for shock in this patient or whatever, even though on this study we kind of knew. 3 hours later, I'm not sure why there was such a delay for us to get our images. You can not only see there's a huge, mostly simple, but debris containing pleural effusion and a ton of consolidated lung in that right chest. I have cut off all of the like landmarks. So just trust me that was that kid's right chest. And before we judge them too much, I do a little bit with education. And if you look at the ABR guidelines and ACGME like mandates, in radiology, we have some radiology residents who the whole requirement for ultrasound scanning themselves is 75 studies. And that doesn't necessarily have to be a diagnostic ultrasound. That can be like ultrasound guidance for a breast biopsy, ultrasound guidance for whatever it is they're doing to place a chest tube, to place an abscess catheter. Most, not all, but most of our ED colleagues have a whole 1-year fellowship that they have done. So the experience is variable, is what I'll say. Now, you can make the argument that these ED point of care people are learning from an ED doctor, not a diagnostic radiologist. And I think that's okay because they're asking clinical questions and answering clinical questions using the tools that they have available. But I do think that we need to do a better job as a radiology community enforcing that these ultrasounds actually be diagnostic. Like I do think that we in general, radiology residents in general, are losing the ability to scan. And so oftentimes before we judge like, oh, we're the radiologists, we know the best, sometimes our ultrasound point of care colleagues are maybe a little bit better than us at scanning. That is a very general statement. It is incredibly variable depending where you are and who you trained with, et cetera. There are certain indications that I would love to never do ever again in radiology. So for example, and some of our surgeons would argue, well, you don't need an ultrasound at all for some of these, like for an abscess, but I think this is a beautiful use of point of care ultrasound. And actually, probably 8 years ago at this point, I learned what's called the squish sign from my emergency department colleagues. So, and looking for an abscess, a superficial abscess, not in a danger area, somewhere where they just want to confirm that there's going to be pus that's going to be drainable, that it's not just cellulitis. I think it is incredibly appropriate to do point of care ultrasound. Yeah, I'm never ever going to use the term squish sign, but I did learn it from them. So you're just looking for that mobile pus when you do compression imaging. They love their signs, and that's cool. There are a few indications in our emergency department that I'm like, okay, so they will do bladder scans. So they do have a bladder scanner, which doesn't have images, but they will also do a quick point of care looking at the bladder volume before they do a urinary bladder catheter. So they want to see, is there urine in the bladder so that if I place the catheter, I'm going to get something out. And I'm just like, you're always going to get something out. I don't know. I hope they're not billing very much for some of these indications because, you know, for like decades, they just put a cath in and got what they could get out. So now I guess they have a hammer, everything is a nail. But anyway, and then there's some things that I'm like, please, yes, great. So this was a patient who came to us first, was an 8-year-old with hip pain and limp. So I'm assuming that they had a high enough pretest probability that if they found fluid, they would tap it. And so they did a hip effusion point of care ultrasound, and their images are almost as good as if obviously the quality is not as good. Our sonographers would get cines. They would show me just a little bit more. Also, their measurement is kind of funny, but that's okay. I hope that if they had fluid, it would have been like that they would drain it. So I feel like sometimes they will image something, and regardless if they see something or not, even in radiology, when they order a radiology ultrasound, a diagnostic quality ultrasound, sometimes regardless of the outcome, their management will be the same, right? So I hope that this was a patient that they had a high enough concern for septic arthritis versus just a transient synovitis or something like that. Okay, this was another patient who had complex medical history. You can see some vertebral anomalies, multifocal pneumonia, so in the left retrocardiac region and right upper lobe were some opacities. And they're doing this more and more. They're looking at the IVC for fluid status, and then to help them determine the etiology of shock when a patient presents with shock. So is this like a low volume versus a high volume state? Now, in this situation, they probably could have like determined just from the clinical picture that the x-ray was positive. This patient had opacities, probably that this patient is in septic shock from pneumonia, but they're using this to help triage patients more and more. And this is their interpretation. Like they're looking for it to be not too full, not completely collapsed, and a little bit variable with respiratory movements. Okay, this was a patient. This is one of my last examples, and then we're going to talk a little bit. This was a super cool case. It was a 9-year-old, and this was the indication, concern for appendicitis. And our techs, of course, are going to look for the appendix, but then the protocol is they get cines of the entire abdomen. So transverse, superior, inferior cines of the entire abdomen. And this one is just not playing all by itself for some reason. So here we go. It's not the appendix. I'm going to let this play a couple of times. Hopefully it will. This is a ginormous intussusception. And I love this case because we always talk about, you know, how can we tell large bowel versus small bowel intussusception, like small bowel versus ileocolic intussusception? Like, do I need to treat this? Number one, we're in kind of a weird spot in the abdomen. She's in the central abdomen, at least is where her marker is. Hold on, I have a SAG of the same thing. And I also love this case because you can actually see the outer wall detail of the bowel. So you can see that the bowel on the outside has valvulae conaventae, so like little tiny things as opposed to haustra or like just like you know, it's not colon. You can tell that the outside of this is small bowel. But as I was like, oh, everybody gather around, check out this cool case we had earlier today, I noticed they did a point of care after our diagnostic quality ultrasound. And I actually sent an email that was like, what are y'all doing? And their images were very different. So they did catch it just a little bit, that small but large, very long segment, small bowel intussusception. But they more did a fast study. So I guess this patient's clinical status had changed. And so they were looking for large fluid. You know, they again looked at the IVC, and they like to like help them with the clinical status of this patient. I know y'all saw that there was a CT, so of course I'm going to show it to you, even though this is an ultrasound conference. So this was a kid who had a small bowel hematomatous polyp. Obviously, this is not a just routine run-of-the-mill small bowel intussusception from like an enteritis or something. So this patient had a pathologic lead point, and yes, that is a volvulus. You can kind of see that swirling of stuff. Honestly, the coronal is maybe the best for that. My learning points from that case were, number one, we probably should, so that this was one of those cases where the tech came in, was like, oh my God, what's happening? Something is wrong. This patient is very sick. I don't like this. And she kind of stopped scanning. So my take home point is, number one, look for the superimposed volvulus, like look for the other stuff, continue through the entire completion of like answering the question as best you can. We probably should have seen the volvulus on the ultrasound, although this was not the typical midgut volvulus. This was like a, in the central of the abdomen, small bowel intussusception with superimposed volvulus. So would we have been able to see it? I'm not sure, because it's like such like, we need a bigger field of view sometimes with ultrasound to see some of these things, but we didn't even look for it in this case, and we should have. My second learning point from this is almost always the point of care is looking for specific things. So they're trying to answer something specifically, like, should this patient not go to CT and go straight to the OR? Like, I'm worried, should I call the surgery fellows attending or whatever? So that was my other learning point from this. Number one, don't be offended. Like, it's cool that they're also doing an ultrasound. But I will say I have some major concerns sometimes with point of care ultrasound. So one misconception, at least for me, I was always told you can't bill 2 abdomen limited ultrasounds in the same day. And here, at least, I'm told that's not true. So as long as it's in 2 separate settings, you can bill the same exam twice. So like an abdomen limited looking at the appendix, if the patient goes away and comes back, and then we do an abdomen ultrasound limited for intussusception, which why would we do that? But if that were to happen, that would be billable. So similarly, I think we can bill for point of care ultrasound performed the same day as a diagnostic radiology performed ultrasound at this institution. I can't speak to if that's like a nationwide thing or if that's just a Pennsylvania state thing. My biggest concern sometimes with some of these patients is, especially when you have a toddler who is just ticked off, not wanting to be touched, is I don't want them to do their point of care ultrasound before that patient comes to me. Because I don't want them to be like, even like, why are we doing this twice? I just had this. Like, as long as the question is like, as long as the patient is stable, I would like for them to come to our ultrasound first. It's a dark room, our techs are so good. It's not like the crazy, loud, chaotic ER. So if they're going to do a similar, from the patient's point of view, study twice, I would love for it to be us first when at all possible. I also hope that whatever they're doing is going to be actionable. So if they find one thing versus another, it's going to change what they do. They also need to have their own QI process and education process. So that missed humongous pleural effusion that was called small, that when somebody showed that to me, I had already seen that, or whatever. When I had brought that to the attention of like the head of point of care ultrasound of the whole entire hospital, they had already seen it. And so education had already been provided. So they need to have, just like us, we're not perfect. We need to learn from our mistakes and learn how to improve to be even better. Same for them. Okay, how do you guys handle point of care at your institution? Number one, are you involved with the training, the QI, any of that stuff?
So it's been kind of interesting. So the infrastructure for POCUS at my institution has been very mixed. So they established a POCUS committee probably about a year ago now, and they asked me to be on that. They asked for one representative from every different subspecialty that potentially going to use ultrasound. So it's a very mixed group of a lot of different subspecialties. It's very interesting to like kind of see how everybody is doing it. I would say our ER has the most kind of fleshed out way of handling this, and I think they do a pretty good job for the most part. Everybody else is not so great. Like the whole like credentialing thing is there's not really a set precedent for how these people get credentialed. The billing is all over the place. The image storage is all over the place. Like a lot of people are just, they buy a Lumify on Amazon, they bring it in, they're scanning people. Like they're not saving images, they're not writing a report, they're not billing it. Like they're just, that's happening to some extent, I think, for like the hospice and all that. So it's been very interesting. So they're trying to homogenize that. They recently just got funding from our institution for a middleware platform so that they can do the QA and the education and writing reports and all that piece of it. So we're getting that implemented, which I think will really help with kind of that quality piece of it. But yeah, so overall, it's very interesting how people do it. I would say our ER and specifically, we have a probably 3 or 4 people that are really good at it, and they're kind of the main people, and then everybody else is kind of still nervous about it, like they don't want anything to do with it. So it's kind of mixed, even just the care that's delivered to patients, just kind of depending on who's taking care of them. Like some of them will get a point of care ultrasound, and whoever's doing it that day was very comfortable with it, and that's all they'll get. Other people will come through radiology, so that piece of it's also kind of interesting. But um, the other kind of thing that's interesting is that the image storage, our administrators have been very reluctant to have point of care images stored in our packs just because we pay for that out of our kind of, piece of the pie. As far as like image storage is not expensive, but it's not really cheap either. So like having a bunch of different people that are having point of care images stored in our packs is not insignificant, but it's also beneficial to us to be able to see their images if we're using it for comparison. Like having them stored in a totally different place that we don't have access to is also not ideal. So there's so many moving parts of this overall. It's very interesting to be at least a little bit involved in it. But yeah, it's a very kind of complex infrastructure overall, I feel like.
Do you ever offer to help train anybody? So like especially our GI colleagues, they're wanting to do more and more bowel ultrasound. I feel like we
Right.
touched on this in the past.
Yeah. I've definitely offered. I'd be happy to, but I feel like they're kind of not stubborn, but they kind of want to have it be their own thing. Like they don't necessarily want our help sometimes, at least here. So I haven't formally been involved with that, but if they needed help, I think we're definitely, equipped to help them if it's something that's kind of in their wheelhouse. So
Yeah, I've lately been saying absolutely not. We like certain people, I'm like, yes, I'm happy to help you specifically, but I'm not going
yeah,
to train. Like I have a hard time keeping my own techs trained, especially with some of the
yeah,
turnover we had within the past decade.
yeah,
So I'm like, no, I don't got time for that.
yeah,
But good luck. I did rather than help train some of them, I helped with like the not credentialing, but like the approval process. Like I looked at their images to be like, yeah, okay, that's, you know,
yeah.
that what they've said they looked at, that's what they looked at basically. So
Right. Yeah, I think the QA piece probably makes more sense for us. Like, yeah, I think the training is, definitely much more of a big lift than, but I think QA is, something kind of what we, image evaluation is kind of what we're the experts at. So I think that makes sense for us too.
okay, I think I have one more example that I was like, okay, so this was the chest x-ray in a kid who had a cough and fever, probably an asthmatic who or somebody who was coughing and then coughed against a closed glottis, ruptured an alveolus, and then had not only pneumomediastinum, but a pneumothorax. You can see that. I meant to put an arrow on this. I'm realizing I did not, but you can see there's a pneumothorax anteriorly in this supine image, in addition to all that like soft tissue gas. Maybe I just gave y'all a blown up image. Anyway, left-sided pneumothorax. And this was the thing that happened. Again, I looked in the chart for whatever reason, and then I could see there was a point of care ultrasound of the chest. And here they were looking, I guess, to confirm maybe that there was indeed a pneumothorax. So this is a nice example of on the right-hand side of the image, you can see those normal pleural interlobular septal lines, those echogenic comets. And then on this side of the image, the left side of the image, there are not those normal lung markings. And you can sort of see that lung point sign. So right where you don't see those comet tail artifacts and where you do see them is where that pneumothorax is. Stolen straight off of YouTube. So this is normal, they call it lung sliding, where you can see these, it's the interlobular septa that we actually see move as the patient breathes. When you have air there, you have air reflects all of our ultrasound wave, and so you don't see those interlobular septal like lines moving up and down. You just see the air. So if we were to look with our ultrasound transducer here, we would just see no septal lines whatsoever. When you're looking for a pneumothorax, or when our clinical colleagues are looking for a pneumothorax, they are putting their transducer right where they're trying to find where it's air in the pleural space and then air in the lung itself. So that is where their transducer is in this case. We have in the past been asked to look with ultrasound for pneumothorax, and we no longer will do this anymore. There's only a few indications that we're like, no, we aren't doing this. This I believe to be truly a point of care ultrasound indication. I'll talk a little bit more about sensitivity specificity in the FAST section, which is coming up now, actually. Anything in the chat? Any other questions or comments you guys have about point of care? I know I'm going to get some angry emails and comments, and you know what? I think we should all work together to take the best care of the patient always. So.
Yeah, the only other thing I forgot to mention earlier on the billing piece, at least for us locally, like we've been told that we can only bill one time. So we've kind of come to an agreement with them if with the ER in specific, that if they order like an ultrasound limited abdomen and they have already done one point of care, then radiology is the one that gets to bill for it. But so at least for us, and then you had mentioned like appendix and intussusception, like we have been told we can't bill two separate times for the same CPT code in the same visit. So like those, if they end up scanning them separately, like we only bill once for those.
Yeah.
So at least for us, that's how it works here in Colorado.
That's where I was under that impression for so long. And I don't know if this is a UPMC thing, because UPMC is billing themselves basically. So the insurance plan is getting billed by the whatever provider. So yeah. Anyway.
Yeah.
Interesting. I'm so glad that I don't have to deal with billing as much as some people do. So anyway, okay. Moving on to FAST scan. So this was a toddler who fell 10 feet onto his back. He eventually did have a little compression fracture of one of his thoracic vertebral bodies, but he had a quick head CT at 7:06 p.m. Cervical spine, I'm only showing you one of those images from a few minutes later, and then a supine portable chest in the trauma bay like immediately after that. And the FAST was done like sometime in between all of that. I meant to like put the actual, maybe I did put it here and this is blocking me. It didn't. Quickly after that. And this patient, because the focused assessment with sonography for trauma was negative, did not have any other abdomen imaging. So I don't have a CT to show you that, oh yeah, this was a legit negative FAST. I loved this article. I always learned something from a radiographics article or an AJR review article, a radiology article, or a pediatric radiology article. So just briefly, all of these are point of care studies. So this is why we're still talking about it right now. We don't perform these in radiology because we are looking for other things. So the common like baseline bread and butter FAST scan is only 4 views. So looking for fluid and part of the liver in the hepatorenal space, looking at the splenorenal space, looking for fluid in the pelvis or blood in the pelvis, and then the subxiphoid view looking for pericardial fluid. There's something called an E-FAST or an extended FAST, and that adds that ultrasound looking for pneumothorax, depending which, like, there's a whole bunch of different acronyms where they're like, oh, looking for congestive heart failure, looking for fluid status, and they have all these silly names like a card, like each of the things is an acronym of like what they're looking for or assessing. There's like the pumps and the pipes is like one of the other FASTs, which is whatever. These are not things we do in radiology. So when we get asked to do a non-contrast ultrasound in the setting of trauma, number one, that is incredibly rare. Number two, we're doing an abdomen complete ultrasound. So we're looking at the organs, we're looking at the, you know, we're following our typical protocol. We're not doing a FAST scan. When we get an order for a non-contrast abdomen ultrasound in the setting of trauma, just like you were saying, Jeffrey, I know that somebody's in the ED who does not feel comfortable doing a FAST scan themselves. Depending what they're looking for, they're going to be looking for they're going to follow variable protocols. But in general, it is just that quick assessment, looking for major fluid to do stuff. So the literature about the performance of FAST is quite variable, and part of it has to do with all point of care ultrasound. It depends like the quality of the study, I would say. So when FAST initially came out a few decades ago, they were comparing to patient outcomes. And so when we would see like a low grade laceration or something like that, that would be missed on a fast, of course, but those patients typically did well. When they started to compare with CT, of course, the sensitivity decreased because, of course, smaller things without fluid, they're not going to see as much as well on a fast. So what the sensitivity for fast looking for free fluid, depending what study you are looking at, is anywhere from about 70 to almost 100%. Solid organ injury is less accurate. And these are all non-contrast studies. I just need to say that again. So in stable patients, so patients who are clinically well, the injury is underestimated by FAST. Specificity is a little bit higher. So when they see fluid in the setting of trauma, obviously this is a FAST in the setting of trauma, or they see evidence of an organ injury, they're pretty specific. So the differential is not very high. When they're looking at, I thought this was interesting, looking at hemothorax and pneumothorax at an extended FAST compared to a chest x-ray, point of care ultrasound, if you look at the literature, does better. Now, I have several things I would like to say about the quality of these study designs, the quality of the chest x-rays. So were they only looking at the, pardon my French, the crappy supine portable chest x-rays done in the trauma bay? Of course, we're going to be more sensitive when we have a good upright two-view chest, but these patients are often very unstable and we don't have that luxury. So this is sort of the protocol that our institution uses. So when a patient comes with abdominal trauma, they are categorized into stable or unstable. And oftentimes a fast exam is done in the ambulance before the patient even gets here. So, or before they even get to wherever it is that they're going. So and most trauma imaging does not happen at this institution. It happens at UPMC, wherever the patient is, and then later the patient gets transferred. So anyway, so often what happens is the patient is categorized as stable or unstable. They do the fast, and then that additionally helps them triage. So an unstable patient will go straight to the OR. A patient who maybe has there's a question of what they need to do with, if the fast is negative, they'll go to the CT scanner. So this is an adult protocol, I have to say, but for the most part, this is what is done here. And then if you have a stable patient, again, you get triaged. If you have a positive fast, you go to the CT to grade the extent of injury, or you go to clinical observation. At our institution, we always get labs. So if you have a negative study, you still have the clinicians have an additional way to know that the patient indeed is negative for trauma. So they will look at liver enzymes. They will look for blood in the urine, stuff like that. This was one of the questions from the pre-submitted questions. Do you allow routine grayscale ultrasound in the setting of trauma? We don't do fast exams. We will do, again, a non-contrast abdomen complete. And that's usually when there's somebody in the ED, or there's nobody in the ED rather, who is comfortable with point of care ultrasound. How about you guys?
I said we try to avoid this as much as we can, just because the sensitivity is so low. It's like, I mean, it's almost a coin flip. Like if the ultrasound is negative, we haven't excluded a solid organ injury, they're going to need a CT anyways. If it's positive, they're going to want a CT anyway. So sometimes it feels like an unnecessary middle step. I would say most common place we see this is that they have kind of a low pretest probability. They're not that worried, but they feel like they want to do some kind of imaging, which, I feel like contrast ultrasound might be a good way to fill that gap. But in general, we try to not go down this road just because I feel like it's oftentimes going to lead to more imaging and not answer the clinical question. But
yeah, for us, when the liver enzymes or whatever it is that they're looking at are abnormal, they go to CT almost always, and we don't have to do this step. This is like when the clinician is either not super familiar with the clinical algorithms here, or something else is going on, like the mechanism of injury, like sounds like this patient should have something, but like everything else is fine so far. This is not commonly done, I would say. It's like,
yeah, I think from my experience, we don't really use that as like a substitute for like their version of fast, or it's usually, if there is true trauma, it'll go straight to CT with IV contrast. And then this rarely happens, thankfully, and it is in the setting of like, oh, something very minor happened like 5 days ago and they're here now, and we just want to make sure there's nothing crazy.
Yeah, sometimes it's for the parents. Yeah,
Yeah.
agree. Okay, just some examples of abnormal. So this is the subxiphoid view showing pericardial fluid, liver laceration, like high grade. Why? Like this was before the patient then obviously went to the OR. High grade splenic laceration on fast before the patient went to CT. Okay, I don't think we actually have time for a contrast enhanced ultrasound. What do you think? I have way too many slides to talk about contrast enhanced ultrasound in the setting of trauma.
I think that deserves its own
Yeah.
session, Judy.
Okay, great. So we'll have ED part 3 at some point, I guess, then. You stop sharing. Well, any questions in the chat or anything else that has come up?
There was one comment from previously about the appendix, about the kind of QA. Somebody said that they used to have 2 sonographers had to scan a patient before they called it non-visualized. I think that's an interesting idea. I don't know how much our sonographers would like it, but yeah.
So we almost always, we do have 2 sonographers that are present, but sometimes they're like scanning, they're like, an hour behind because there's like an ED, an ICU, somebody's getting a transplant in the OR. And so we don't always have the bandwidth to do that.
Right. Yeah.
I love that idea though. Ideally, I want a sonographer to check another sonographer's images all the time. I want them to draft my report for me, input all the measurements for me. But
yeah, that's what we've kind of started exploring the idea of like the advanced practice sonographer. I know a lot of adult practices that use it. I don't think it's super widespread in the pediatric world, but I'm currently trying to advocate for that to happen here. Like, having a sonographer that, like you're saying, can check other studies that can help back and that can potentially predictate studies that, could talk to clinicians, have some of those other kind of intermediate conversations about, what protocol is appropriate, all that kind of stuff. I think that'd be super helpful, but yeah, I'm working on it.
we're starting that exact same conversation.
Yeah.
The issue is like staffing. So I think what's interesting in our practices, our techs are like not controlled, if you will, by me at all. So they get paid from like the tech side of things, not the physician side of things. So I think there are lots of restrictions on how they can get paid as a tech. And there's no like super sonographer like status yet. There's just like lead tech, clinical educator, that sort of ladder.
Right.
And so I think what we're going to maybe start to do is like, even though they're not an advanced practitioner, see if we can hire them and have them function as an advanced practitioner.
Right.
I don't know, to be continued.
Yeah. I think that's a challenge for us too. It's like we have an APP in fluoroscopy. They do a lot of studies. They're hired by University of Colorado, which all of our radiologists are employed by University of Colorado, but we work at Children's Hospital. But then all the sonographers are hired by Children's Hospital. So yeah, that's a big part of the conversation is I think that APP they're hired by the university, but I think a portion of their salary is funded by the Children's Hospital. Like I think kind of like a hybrid thing. I'm not sure all the details on how that works, but I'm gonna have to look into that. But that's a big kind of piece we're discussing right now is what that piece of it would look like.
Interesting.
Yeah.
Tell me how you do it. And then I'll follow your lead.
I've heard on the adult side, a couple of people I've talked to, they've estimated that they take about the advanced practice sonographers account for like a third of a radiologist FTE. So everybody that I've talked to really loves having them. I think it sounds like they're super valuable and can play a very big role in the kind of ultrasound, workflow. So I'm excited about the idea. I think it's just going to take a little time to get there.
Yeah, they can make us much more efficient as radiologists.
Right. Yeah, for sure.